I am Dr. Ramesh Venkatraman, Senior Consultant Critical Care Medicine at Apollo Hospital and Director for the TACT Academy of Clinical Training. Today, I'm going to talk about the rational fluid therapy in the ICU. When we say rational, I'm going to talk about it from a clinician's point of view. Why do we give fluids? When should we give fluids? What fluid should we give? How much should we give? And with those thoughts, I'm going to conclude my talk. I want to use the existing evidence to try and answer these questions. The first question is, why do we give fluids in sepsis? First, there is going to be absolute hypovolemia if there is significant intravascular volume losses that happens like diarrhea, diabetic ketoacidosis, etc. There is profound vasodilatation that happens in sepsis that causes a relative hypovolemia, and there can be third spacing that happens because of capillary leak, again decreasing the intravascular volume. All these together can cause hypotension, and we need to react to the hypotension. If not reacted on time, they lead to a low cardiac output state and frank shock where there is end organ damage or dysfunction that starts to happen. To reverse all this, the commonest armamentarium we have is giving IV fluid resuscitation for patients in sepsis. So when is giving fluid helpful? When there is gross intravascular volume depletion, like a patient with diabetic ketoacidosis, there is no reason why we shouldn't be giving fluids to those patients. If the patient has a low cardiac output, then I would like to give fluids if the patient is fluid responsive. When I mean fluid responsive, it means that if I give fluid, my cardiac output should go up. If it doesn't go up, then there is no point in me giving the fluids. So fluid responsiveness just means the rise in cardiac output is reasonable if I give a fluid bolus. 2, this fluid bolus, improved cardiac output, should be reasonably sustained. If it goes up temporarily and then comes back down again, then there is no point in giving the fluid. We would only add more and more fluids to the patient without any significant benefits. And this should in turn improve the organ perfusion and the flow. Therefore, fluids would help if the changes in stroke volume and cardiac output are sustained. Lastly, the benefit should outweigh the risks. If the patient already has interstitial edema or pulmonary edema, giving more fluids and causing more edema is only going to do more damage to that patient. If there is a lot of venous hypertension that is present that can impair the venous return, it can increase the backflow pressures of the organs, therefore causing edema and organ dysfunction. And fluid bolus itself can worsen the capillary leak, as I will show you later. So fluid should be helpful, the help should be sustained, and the harm caused by fluid should be much less compared to the benefit. Only then can I safely give fluids for patients in sepsis. The first study that looked at fluid resuscitation as a whole in sepsis is the EGDT study done in Detroit by Dr. Manny Rivers and his colleagues. They formalized the protocol for resuscitation of sepsis. As most of you know, the main target was a CVP first, followed by mean arterial pressure, then a mixed central venous oxygen saturation. A CVP of 8 to 12 was the target for intubated patients. For non-intubated patients, it was slightly lower. They gave fluids till the CVP reached 8 to 12. Then, if the blood pressure was low, they added vasoactive agents to keep the mean arterial pressure more than 65 and less than 90 millimeters mercury. And then they had a special central venous catheter by which they measured the central venous oxygen saturation. It was less than 70, they either transfused blood or added a little bit of inotropic support like dobutamine in these patients. And if all these goals were reached, the patient was considered to be adequately resuscitated. They followed these patients in the emergency room, and they showed that this early goal-directed therapy had a 16% absolute risk reduction, which is huge. 1 in 5 patients were saved by this strategy compared to the control group. What was done in the first 6 hours in the emergency room translated to both hospital mortality, 28-day mortality, and even 60-day mortality, indirectly telling us that whatever damages happen to the organ seem to happen very early on, and if we can reverse those damage that happens earlier on, maybe we can save a lot of people's life later on too. So this was the first study that kind of brought this concept of aggressive fluid resuscitation in a protocolized way out, and a lot of people said this made sense and maybe we should follow it. However, this study did not mention the incidence of acute kidney injury, and hence we don't know whether patients had more or less renal failure in each of the groups. Subsequent to the single center study, there have been 3 large multi-center studies done in 3 different continents. The PROCESS study done in the US, the ARISE study done in the UK, and PROMISE study done in Australia. They gave anywhere between 2 to 3 liters of fluid in mostly about 1,300 to 1,500 patients. All the 3 studies used the Emmanuel River EGDT protocol as one of the arms. There were some variations in the other arm depending on the study, but in effect, all 3 studies did not show any significant improvement in survival with EGDT. It is important to note that from the original EGDT study to the conduct and publication of these studies, there was more than a decade by which sepsis resuscitation had changed, and therefore the new baseline was completely different than the original baseline which the Detroit study had. When all these 3 studies were put together, they found that 2 liters of fluid was given on an average, which turns out to be 27.5 ml per kilo. There was absolutely no difference in survival benefit between the 2 groups. However, there was a greater use of intensive care because we put more central lines, more A lines, checked more lactates, higher vasopressor use, and therefore the cost was higher without actually improving survival of these patients. The surviving sepsis guideline recommended fluid bolus of 30 ml per kilo of body weight, which is essentially largely arbitrary but extrapolated from some of the studies that I had shown earlier, where most of the fluid resuscitation happened roughly around 25 to 30 ml per kilo body weight. So the evidence base itself for 30 ml per kilo is weak, but it's an extrapolation and it's used as a guidance for most people to say how much fluid should be considered in patients with sepsis, and it is not based on robust evidence. So now that we know we are going to give fluids, the question is, what fluid are we going to give? Are we going to give a colloid or a crystalloid? The largest study that has compared them head to head would be the SAFE study done in Australia, where they randomized patients to either 4% albumin or normal saline. They took about 7,000 patients in shock and randomized them to albumin versus saline. They found no mortality difference between the 2 groups. This study is largely quoted to say that albumin and saline are equivalent and therefore saline could be comfortably used for resuscitation. It is also used to argue the other point of view that albumin is relatively safe compared to the discussions that originally said that it increased mortality and therefore albumin can be safely used for resuscitation. However, there are important points that needs to be noted here. Number 1, the Apache score of these patients were 19, which is not very high. The mean arterial pressure for most of these patients on an average was around 75 millimeters mercury. They had about 90 to 100 ml of urine the previous hour, and almost half of them did not have any organ dysfunction. So it's a less sick patient, not much organ dysfunction, reasonably good hemodynamics, good urine output. This is the kind of patient where I may not even give fluids. So all this study shows me is that if you give fluids to somebody who doesn't need it and you give only 1.2 liters, it doesn't matter what fluid you give, rather than saying albumin is safe or not safe. They also did not show any differences in any of the secondary endpoints like survival time, ventilation time, duration of dialysis, or length of stay in the hospital. The next study that compared crystalloids with colloids is a pragmatic study. They did not stick to one fluid. They used all kinds of colloids or all kinds of crystalloids, but the patients were resuscitated either with colloids alone or with crystalloids alone. They randomized 3,000 patients. Again, no significant differences between the groups in terms of survival. So then the question comes, if colloids and crystalloids are the same, can I use any colloid? The answer is no. This is an observation study called the CRICO study, where they looked at 1,000 patients. All patients were in shock. Patients were categorized as 4 categories. Either they received only crystalloids, hypo-oncotic colloids, hyper-oncotic colloids, or hyper-oncotic albumin. What does hyper-oncotic colloid or albumin mean? When I give a fluid, The traditional teaching is that the fluid diffuses across the vascular space into the interstitial space and then the intracellular space. The effective intravascular volume rise is much lower than the volume we have infused on the patients. However, there are certain fluids which have very high oncotic pressure where when they are infused, they stay inside the blood vessel. Not only do they stay inside the blood vessel, they also drag the water outside the vessel into the vessel. Therefore, the intravascular volume increases by a volume more than the volume that was infused. The classic example is 20% albumin, which is considered an hyperoncotic albumin, and there are certain starch solutions considered hyperoncotic at this point of time. So they compared these four fluids. Intuitionally, you would say that if there is a fluid that is able to stay in the vascular space longer and also pull more fluid into the vascular space, it should be good for patients with sepsis. However, they found that such fluids like hyperoncotic albumin or hyperoncotic colloids had a higher chance of mortality, higher chance of acute kidney injury, higher need for renal replacement therapy, death at ICU discharge, and death at 28 days. Why does this happen? If you think about it from the glomerular level, you will realize that glomerular filtration will be prevented if most of the fluid hangs in the intravascular space and does not leak out of the glomerular capillaries. Therefore, there will be a decreased GFR and worsening acute kidney injury when hyperoncotic fluids like 20% albumin and hyperoncotic colloids are used. The first study looking at starch solutions is the YSEP study. They randomized 530 patients with sepsis. They either used a 10% pentastarch or modified Ringer's lactate. Another important noteworthy finding in all these studies is the traditional teaching is one would need 3 times the volume of crystalloid to replace the volume of colloid. Meaning, if I gave 1 liter of colloid to replace the same amount of volume, I would need 3 liters of crystalloid. This was not shown to be true. If you look at the SAFE study, the ratio of colloid to crystalloid was 1:1.4, meaning for every 1 liter of albumin, 1.4 liters of crystalloid was used. In YSEP study, the ratio was 1:1.3. So clearly, the volume requirement in sepsis of crystalloid is not as high as it was projected earlier. They also showed that there was a higher rate of acute kidney injury in the starch group. The problem here is the dose given was very high and patients were not very sick. These patients also had a higher mean arterial pressure and a lower Apache to start with. The two large studies looking at starch solutions are the 6S trial, where traditional to the old 10% starch solutions, they used the 6% starch solution. They compared it with Ringer's acetate solution. It was done predominantly in Scandinavia. They found that starch solutions did not have a mortality that was worse, but probably had worsening acute kidney injury. Again, a large amount of fluid was given. Patients were fluid overloaded, so it was difficult to say whether it was the starch or the fluid overload that was very harmful in these patients. The Australians, as always, do large studies with 7,000 patients. Again, they like to give fluids to people who probably don't need fluids. The mean arterial pressure again was more than 70, CVP was 9, SCVO2 was more than 65 to 70% in a lot of these patients. They showed no difference in outcome between colloids versus crystalloids. Colloids predominantly starch solutions versus crystalloids in this study. However, they did show that renal events with AKI and RRT are worse. They also showed that the fluid ratios again 1:1.3. So it looks like in sepsis, the amount of crystalloids to colloid ratios actually 1:1.3 rather than 1 to the traditional 3 that we have been talked about. So in summary, should I use colloids? No, colloids are not superior to crystalloids based on the SAFE study. Not all colloids are the same. I should probably stay away from the hyperoncotic colloids like albumin and starch solutions. Understand that colloids do not decrease the amount of fluid that I need to give significantly, because we saw that we need to give only slightly more crystalloids to achieve the same effect. Stay away from starch solutions. Although a lot of the starch studies are limited by fluid overload, excessive dose of the starch solutions given, there seems to be an increased risk of acute kidney injury, renal replacement therapy and mortality. Therefore, at this point of time, the recommendation is stay away from starch solutions. If colloids are not beneficial, they can be potentially harmful and are more expensive, then should I just go with a crystalloid? If I have to give a crystalloid fluid, what crystalloid should I give? The two common crystalloids that we would consider isotonic would be normal saline or Ringer's lactate. There has been arguments that normal saline induced hyperchloremia can be significantly bad. Chloride acts as a potent vasoconstrictor at the kidney level, therefore can cause acute kidney injury. Hyperchloremia can cause acute kidney injury. So this study was a cohort study where they took 6 months of a year in Australian ICUs where they gave a chloride liberal fluid. Then the same 6 months, the next year, patients got only chloride restricted fluid across various ICUs. They found that the fluids used were different at different times, but it's either chloride restrictive or chloride liberal. They found that there was more acute kidney injury and renal replacement therapy in the group that got chloride containing fluids, clearly tying with our understanding that hyperchloremia is a renal vasoconstrictor by several mechanisms causing AKI. This is the next randomized control study, 2,200 patients, volume of saline versus a non-chloride containing fluid on an average given was 2 liters. No difference between the saline group and the buffered crystalloid group in this study. People argued that maybe 2 liters is too small a volume to create a difference in this group. A large study looking at ICU patients showed that there may not be a mortality benefit, but there may be trends towards improvement with certain parameters when you use a balanced crystalloid compared to normal saline. So, in summary, fluid therapy, what we know for sure is that colloids are not superior to crystalloids based on the SAFE study. Starches increase AKI based on the CHEST study and the 6S study. Understand that those studies are limited, but still the data is very consistent that we should stay away from these two. Balanced crystalloids make sense, but we don't have any definitive data based on randomized controlled trials. But I think avoiding hyperchloremia would be prudent when we give fluids. In terms of use of albumins or gelatins, the evidence is not yet convincing. SAFE study may have shown that albumin is reasonably safe, but with the cost element in countries like ours, I think it is better to stay away from expensive fluids when cheaper fluids can probably do the same amount of work. Surveying sepsis guidelines says clearly that we recommend against using hydroxyethyl starches for intravascular volume replacement in patients with sepsis or septic shock, for which the evidence is robust at this point of time. Okay, I know that we are given fluids. We have kind of gone through the literature on what fluids would be good, but do fluids actually work in sepsis? Let's see if there's any evidence to say fluids work in sepsis. Data shows that only about 50% of unstable patients respond to fluid, which is a coin toss. Half of the patients are not going to be responding to the fluids that you give. We want the fluids to improve the cardiac output and improve the perfusion of the organs. There are some people whose cardiac output does go up, some people where the mean arterial pressure goes up. There are studies that have shown that the rise in mean arterial pressure is about 10 millimeters mercury, but it does not sustain for more than an hour. So we may be doing temporary good, but then ultimately we may also be doing a lot of harm by repeatedly giving fluid boluses. There is a lot of data to say that there can be significant cardiovascular collapse associated with fluid bolus. In patients who have a high sympathetic drive because of the underlying illness, you may have a high sympathetic tone causing significant amounts of vasoconstriction. Moment fluid bolus is given, this sympathetic tone relaxes a little bit, the systemic vascular resistance decreases, and therefore there can be profound vasodilatation that happens. There is indirect evidence to support this clinically, which I will quote later in my talk. The effects of fluids can be short-lived, both the hemodynamically, mainly because of leaky vessels. You give fluid, initially the intravascular volume goes up, stroke volume goes up, cardiac output goes up, blood pressure goes up, but then there is a leaky vessel. So whatever you give, vessels are going to leak, and this fluid is going to diffuse across and cause more and more edema, and the hemodynamics are going to revert back to the baseline without a sustained improvement. There is data to say that fluid bolus actually injures the endothelium, causing more and more leakiness. I will show you data regarding this also. Is there any study that has looked at what happens after we give a fluid bolus? This is from the FACT trial, which basically took patients with ARDS and gave fluids for conservative PA pressure, CVP, or a more liberal fluid strategy. They went back and looked at what happened to patients who got fluids. They actually recorded about 570 fluid boluses. Per patient got about 5 fluid boluses. The indications of fluid bolus was classified as shock in 1/3 of the patients, low urine output in 1/4 of the patients, or just a mere low wedge pressure in about 40% of the patients. As per our definition, a 15% increase in cardiac output is generally considered responsiveness to fluid. In this study, they found that only 23% of the fluid boluses resulted in cardiac output increase of more than 15%. In a sense, almost 80% of the time, fluid boluses did not improve cardiac output at all, and therefore other parameters. There was no difference in terms of the responsiveness, whether the change in CVP was less than 2 or more than 2. There was no difference in the responsiveness rate despite whichever indication was for what the fluid bolus was given. You can see that the parameters pre-bolus and post-bolus essentially the same. The heart rate didn't change much. Mean increased slightly but then came back. Urine output no change. Cardiac index no change. CVP, PA pressures are variable. So either it is a marker or the hemodynamics, not really a whole lot of change with fluid boluses based on this study. So the next one is a very important study done in New York. They collated data from the New York database for all patients who went through an emergency room for septic shock. They classified the patients into the proportion that reached the 3-hour bundle, sepsis bundle, and at what time point they reached. They found that the earlier you reach the 3-hour bundle, the better the survival. As you can see, as there is a delay in achieving the 3-hour bundle, as patients take longer and longer to achieve the 3-hour bundle, the mortality goes up. What exactly in the 3-hour bundle are we talking about? We're talking about fluid resuscitation, we're talking about antibiotics, we're talking about sending cultures and checking a lactate level, of which the interventions we would be doing are fluid resuscitation and antibiotics. Let's see what the impact of each of these interventions on survival. This is the data on antibiotics. As you can see, for every hour delay in the giving of antibiotics, the mortality keeps going up to 12 hours. However, if you look at the fluid boluses, this is when people complete the 30 ml per kilo of fluid bolus. It doesn't matter when you completed the fluid bolus, there seems to be a flat line, no big difference in the mortality between the group that achieved the fluid bolus earlier versus later, clearly telling that among the early components, maybe evaluating the patient faster, getting the antibiotics in sepsis makes probably much more an impact than aggressive fluid resuscitation. This, along with the previous FACT trial, tells us that maybe not all patients are going to improve with fluids, and therefore the benefit of fluid resuscitation aggressively early enough may not be as high as what we think it was earlier. This is a very important study that happened in Africa. Children with severe infection. They looked at children who got fluid boluses versus children who got fluids without boluses. They found that children who got boluses had a significantly higher mortality compared to children who did not get boluses. Whether the bolus was albumin or saline, it doesn't matter. If the children got a bolus of either albumin or saline, they ended up dying more than the children who did not have boluses. Initially, the interpretation was that in Africa, if you create fluid overload, there were no mechanisms of putting you on a mechanical ventilator or dialyzing, and therefore the consequences of fluid overload were fatal, and these kids who got fluid boluses probably died because of the consequences of fluid overload. When subsequent analysis was done, it was clearly shown that the reason for mortality is cardiovascular collapse. I had earlier alluded to the fact that giving a fluid boluses causes vasodilatation and decreases SVR by mechanisms that I had described earlier, and this could be a factor here where there is significant cardiovascular collapse. It can also be because of myocardial edema. This is a basic science paper where you can clearly see that in the right hand side, when there is atrial natriuretic peptide that is released, you can see endothelial glycocalyx being broken down. The more fluid we give, more ANP is released because of atrial stretch that clearly causes damage to the endothelial glycocalyx and therefore causes more leakiness. In effect, the more fluid bolus you give, the more leakiness you do seem to cause to the vasculature. Consistent data shows fluid overloaded is bad in critically ill. This is the famous PICARD study where they looked at patients with fluid overload defined as more than 10% increase in their body weight from baseline. Clearly showed that patients who had fluid overload tend to die more than patients who do not have fluid overload. This effect is sustained at 30 days, 60 days, and at hospital discharge. There seems to be a dose-response relationship. Higher the fluid overload, more likely you die. There also seems to be a correlation between the duration of fluid overload and death. The longer you are fluid overloaded, you die. You can see the graph on the right hand side which shows that the percentage of dialysis days with fluid overload correlates with mortality. And this may be minimized by CRRT based on this study. The other thing we talk about always is the Frank-Starling's law, where we give fluid and we see whether preload can be increased with which the LV contractility can be increased. What we don't see is the extravascular lung water. This is the curve that was basically described by Dr. Paul Marik, where we see that if you are in the flat portion of the Frank-Starling law, let's say the arrow B, a large fluid bolus is not going to increase your cardiac output significantly. However, the extravascular lung water curve is still steep. Therefore, even a little bit more fluid is going to cause substantial amount of extravascular lung water or pulmonary edema. It is these patients where even a little bit of a fluid bolus is going to be more harmful. Not only are they not going to help you, they're going to be more harmful, and we need to be careful in terms of how we give fluids to these patients. Studies have shown that if there is capillary permeability that is increased, as you would see in sepsis, the amount of hydrostatic pressure one would need to cause extravasation of fluid would be even more lower. The curve is shifted to the left because more and more capillary permeability, less amount of pressure intravascularly is enough to push the fluid out, and therefore in patients with sepsis you don't need high filling pressures to cause pulmonary edema. Even normal to mildly elevated filling pressures can cause pulmonary edema. This needs to be looked into when we resuscitate patients with sepsis. Fluid overload affects every organ, causes cerebral edema, myocardial edema contributing to the cardiovascular collapse, hepatic congestion, gut edema. In the kidney, it can cause increased renal venous pressures and therefore cause something like a renal compartment syndrome. The intracapsular pressure also goes up and that decreases further blood flow to the kidney and causing worsening acute kidney injury. Pulmonary edema and tissue edema. So all these can be made worse or created by fluid overload. One needs to be careful how fluid is administered to these patients. So we have seen that too little fluid is bad, too much fluid is bad. I need to somehow find the right balance where I will not harm the patients more. At the same time, I would benefit the patient with euvolemia. But how do I know when to stop giving fluids? Traditionally, we have looked at fluid responsiveness by various mechanisms. The easiest would be the IVC size and the variability in size. We look at the IVC size. If it's less than 1.5 centimeters or 2 centimeters, and if it's collapsing, we consider it to be fluid responsive. We use heart-lung interactions in several ways, predominantly using pulse contour analysis to look at stroke volume variation, cardiac output changes, and see whether patient would be fluid responsive. If the patient is spontaneously breathing, we can do a passive leg raise and look at stroke volume variation in those patients. In patients who are ventilated with poor compliance, we can use an end expiratory occlusion test to try and assess fluid responsiveness, or try and give a small fluid bolus and then assess the response. As much as I would like to assess the fluid responsiveness, I also want to assess the fluid tolerance. I can do a clinical exam, but RALs occur late, desaturation happens late and is non-specific, so I need better means of looking at fluid tolerance. The commonest way we look at fluid tolerance in the ICU is looking at the lung ultrasound. On the left you see the A-line pattern, and the right you see the B-line pattern. Transitioning from A to B-line pattern tells you that there is increasing pulmonary edema that is happening, and therefore we probably need to stop the fluid boluses given. There are pulse contour devices that give you a value of extravascular lung water. When it's more than 10, it is an indication for pulmonary edema and increased leaky capillaries. That, along with pulmonary permeability index, should tell us to probably avoid giving fluids to these patients, but they are not routinely available. So when would I stop giving fluids? I would definitely give fluids if the IVC is less than 1.5 centimeters, IVC is collapsible, or I have a good stroke volume or a pulse pressure variation which is more than 12% with a passive leg raised. My ultrasound lung shows an A-line profile or an extravascular lung water shows less than 10, which means it's safe to give fluids. I would definitely not give fluids if IVC is more than 2.5, there is no variability, no pulse pressure or stroke volume change, B-line profile on the ultrasound or the extravascular lung water is more than 10. But more often than not, I am going to have a patient who is fluid responsive but intolerant, or fluid unresponsive but tolerant based on my clinical assessment and my parameters that I assess. In these patients, I need to weigh the risk-benefit ratio and then decide whether to give fluids or not. In essence, if somebody is fluid responsive and fluid tolerant, by all means try a fluid bolus. If somebody is fluid unresponsive or fluid intolerant, stop the fluids. If they are in the gray zone, you need to assess the risk-benefit ratio very carefully to see whether giving fluids is going to hurt the patient more or help the patient more, and then make an individual decision for that particular time and go back to reassessing the patient all over again if the shock persists. Conclusions. Fluid therapy must be done after careful risk-benefit assessment, not once, not twice. Every single time you do, you have to be very careful about whether to give fluids or not. No major differences between the colloids and crystalloids. As we thought, colloids do not reduce the volume requirement substantially, so crystalloids do a very decent job and we can stick with crystalloids. Avoid hyperoncotic colloids, predominantly 20% albumin. Avoid starches because there is a high incidence of acute kidney injury and renal replacement therapy. Even though the data is not very convincing, there is enough physiological data and rationale to say avoid hyperchloremia in patients where resuscitation is being carried out. Assess fluid responsiveness, assess tolerance, assess endpoints of resuscitation. Integrate all three to decide whether you need to give fluids or not. Understand that no one measure is reliable and you need to keep using as many tools as possible to try to make this judgment. Understand that the patient condition and physiology changes from time to time, and before each deployment of fluid bolus, one needs to do a very careful, comprehensive evaluation of the above parameters. Use as many tools available to you to decide on giving fluids. Understand that under resuscitation or over resuscitation is inevitable either way. Careful assessment and action will limit the harm we do by giving fluids to these patients. Thank you.